Okay, hi everyone, nice to see you. My name is Gautam. I'm gonna talk to you guys about recent work on the economics of mental health in developing countries. So I just wanted to flag that, I'm gonna talk about some, trends, some big picture ideas. I'm mostly going to be talking about other people's work, but, this comes from, this is going to be sort of a highly selective kind of discussion. So I'm not going to do anything near an exhaustive review. It's going to be kind of speculative, and it's going to be kind of my perspective on how we as development economists should think about and why we should think about and care about mental health. So first, just, I sometimes kind of come across this question of, well, why exactly should economists be studying mental health? Or perhaps I get asked often, what is our comparative advantage in studying it, as opposed to leaving it to the psychiatrists and so on? And here I would first say that, mental illness, things like depression and anxiety, often cause profound suffering. And so they're extremely welfare relevant, and I would argue they're an important end in itself. Right? So as economists, we're interested ultimately in welfare. And I would argue that this is a really important component of welfare that we should, in fact, be measuring. And it particularly matters to economists because there's a lot of evidence that economic forces affect mental health. So when we're evaluating economic policies, we may want to expand the set of outcomes we're thinking about to include mental health. And then the other thing which we know less about, but is a distinct possibility, that mental health itself may affect economic behaviors and outcomes. So improved mental health could have economic returns beyond the kind of welfare relevant notion of health itself. Okay, now, of course, we know that that must be true in general for physical health, right? That people may be able to be more productive at work and so on. Mental health is a bit different because in addition, it may affect the way you think, right? So especially when we think about kind of, the kinds of decisions people might be making, mental health might become important. So what is mental health? I'll start with kind of, there's this sort of a very broad definition, which, I think once you focus on that definition, well, you think, well, then of course, it's almost kind of tautologically, it matters to economists. A state of well-being in which an individual realizes their own abilities, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution to their community. In some sense, that's a lot. That it almost sounds like it's everything that's good is in there. So the focus for this talk is going to be on the two most common mental health disorders: depression and anxiety. Okay, these are sometimes referred to as mood disorders, and and you should think of them as relatively less serious mental health conditions compared to things like schizophrenia and bipolar disorder, which are also important, again, have profound kind of welfare impacts for the people who have them, but affect a smaller share of people. But even so, when we think about depression and anxiety, ultimately, I think we should think about this as a spectrum. There is such a thing as a clinical diagnosis and the person gets called depressed or not. But in practice, really, there's a spectrum where people are going from, think about outcomes like happiness and life satisfaction on one end, and then on the other end, a clinical diagnosis of depression and anxiety. But in reality, it's kind of much more continuous than a distinct cutoff, which is still used for diagnosis and treatment. So there's different types of depression. A very common one, and one that a lot of the literature is focused on, is MDD, major depressive disorder. And of course, the thing to keep in mind, and I feel economists will often ask me, is like, can you measure these things objectively, right? But of course, these are inherently subjective conditions. So depression is defined in the DSM as, a constellation of symptoms, including things like extreme feelings of guilt or worthlessness, hopelessness, difficulty concentrating, difficulty sleeping or instead oversleeping, changes in appetite, fatigue, suicidal ideation, inability to get pleasure out of things, and having some set of these symptoms to be present sufficiently frequently over a 2-week period is really what the clinical diagnosis of an episode of MDD means. Okay, so I'll mention in a bit how economists, studying these things in the field often measure it. Anxiety is often co-occurring with depression, has some symptoms in common, but it's typically more a longer run condition that's characterized by long-lasting and excessive kind of fear and worries that may be disproportionate to kind of, in some sense, the actual objective threat, but then which sort of leading to some of the same sort of problems, fatigue, concentration problems, but then some things that are a bit different, like irritability, muscle tension, restlessness, etc. Okay, but they do sometimes co-occur, not always. Anxiety for a diagnosis typically needs to be present for a longer period of time. Okay, it's less episodic in that sense, and is often a more chronic condition. So how do we measure these things? The gold standard would be a clinical diagnosis by a psychiatrist. How do they do that? They do that by essentially, talking to you, going through this list of conditions, trying to understand any specific special circumstances you may be facing, and so on. Now, that's difficult to do if we're doing, say, studies where we're doing a cash transfer intervention with 10,000 people. It would be very costly to have psychiatrists, interview 10,000 people as one of the outcomes of our study. Luckily, psychiatrists and global mental health researchers have put a lot of effort into developing simple survey questionnaires that pretty directly just ask you about those symptoms. So for example, there's something that's commonly used called the Patient Health Questionnaire 9. That's 9 questions, each about one of the symptoms of depression, just asking you, how often have you felt this in the last 2 weeks? And the answers are sort of not at all, on some days, on most days, or all the time. Okay, so feeling worthless or like a failure, how many days did you feel this in the last 2 weeks? GAD-7 is for generalized anxiety. And these, the nice thing about these measures is typically in almost, in any language, in almost any country that you might be working, you'll find studies that have gone and deployed this survey instrument, have done the gold standard diagnostic interview with a trained professional and have validated them against each other. And these tend to perform pretty well. What you have is, you can use these as a continuous outcome, or you have some cutoff score. So if your PHQ-9 score is above 10, then you're considered at risk of moderate depression. Above 15 is moderately severe depression. Above 5 is mild depression. So, there are sort of these set cutoffs in the literature, of course, with the caveat that I mentioned that, in fact, of course, these things the underlying condition is more continuous than that. Okay. By the way, are we taking clarifying questions or? I'm happy to take questions at any point along the way. Otherwise, I'll get a little bored myself. So please feel free. Okay. So let me tell you a bit about the prevalence and some recent trends when it comes to depression and anxiety.
Yes. I have a question on the previous slide. So when you're talking about PHQ or any sort of scale, there's something to be thought about the cultural context of where these were developed. And my sense is that plays an important role in not just diagnosis down the line, but also sort of trying to understand what these triggers could be. So how do we think about how these transfer or how well they can adapt to developing country settings where we
I'll repeat the question, I guess, for the recording, which is sort of what's the cultural generality or specificity of these measures, and how might they work better or worse in different places. So as I said, on the one hand, these have been actually validated in terms of their specificity and sensitivity in a range of different countries. So if you want to say within India, have people translated this into Tamil and then done it somewhere in Tamil Nadu, you will probably find that study, or in fact, you will find that study. And similarly, you'll find this for many countries. So it does work pretty well. There is some sense, particularly say for the anxiety measures, that there's different scales or these questionnaires for trying to measure anxiety, and some of them focus more on the physical symptoms. So anxiety will often then manifest as heart race or some pain in this clench, the pain in the stomach, or back pain, lower back pain. And there's some evidence that in developing countries it may manifest more in these physical ways compared to in the ways where people report more their internal psychological state. That is certainly true, seems to be true at least, okay, talking to doctors and so on, in how it manifests outside of the context of doing the survey when you show up to a doctor. It's very rare to show up to, say, a primary care place in India and say, I'm here because my mental health is not good, or I'm depressed or anxious. You may often present instead with these sort of physical symptoms, you know? So I think that is different, but it is also true that kind of these measures have been validated in a range of different contexts and seem to work pretty well. I will say there is kind of an interesting, measurement is just a challenge for these conditions. And there is sort of a sort of looming question of, to the extent that you become more, maybe because of cultural changes or the like, or because of some intervention, you might become more aware of your internal psychological state. And how does that affect your propensity to answer these questions differently? I think that's an important and interesting question. And, so I think there's all these studies sort of in the cross-section validating the clinical diagnosis compared to the survey question. But I think we should still have a little bit of nervousness about if you do an intervention like therapy, and part of that might involve reflecting a lot on how you're feeling, does that actually change the way you answer these questions, right? So I think that would be an interesting and important thing to make progress on. Okay, let me tell you a bit about prevalence and recent trends. So pre-COVID, we thought that about 3 to 4, maybe 5% of the world's population suffered from either depression, suffered from depression, and a similar share suffered from anxiety at a given moment in time. There's variation across studies and across countries. So, I would say these are pretty approximate numbers. Depression is actually the world's leading cause of a certain measure of disability, which is years lived with disability. This is partly because it often occurs for the first time when you're a relatively young person, and is something that people may deal with on and off for the rest of their lives. Depression and anxiety together account for 8% of years lived with disability globally. So in the US, for example, something like 24% of Americans seem to experience a clinically significant episode of depression at some point in their lives. It's also, as I mentioned, pretty recurrent, which is that it's, some estimates suggest that about 75% of people with depression end up having more than one depressive episode in their life. And about half to 2/3 of people who were ever clinically depressed are in an episode again in any given year. Okay. I would say, we shouldn't bet our lives on any of these numbers, but I'm, mostly trying to give you a sense that it's a episodic condition that people can cycle in and out of. Often, if you've had it once, you're at risk of having it again, and a lot of people deal with it. Yeah.
So for the GAD, how you mentioned that this floats around a lot. So should we think of this as more like a trait, or is this something that is fixed, or is it really malleable and you would expect to see intervention effects, for example, on a GAD?
Yeah, so great question. The question is about how much are these things like traits versus how much are they malleable? And I would say it's a bit of both. Our best, I think the understanding right now of, say, something like depression, and actually I know a little less about anxiety there, I think I suspect it's similar, is that there is some predisposition to something like depression or anxiety, right? There is some hereditary component to it, like whether that's purely genetic or something else, I'm not sure we know. So you may have some predisposition to it, but then for, say, depression in particular, you're likely to have it be then triggered. Often it's triggered by then some shock, so job loss, breakup with a loved one, something like this, some setback in life, then triggers it. But, there's this cross-section, like some people go through the job loss and don't get depressed, others do. And we think there's something about predisposition there.
Job market, right?
What's that?
You said job market, right?
No. Job market is just a win-win matching process. Ends well for everyone. If you are doing a PhD in economics, life is gonna be really good. In the medium term, I promise. So really, the stakes are lower than our students often think. Okay. All right. So sorry, and I'm going to show you that these things are kind of, in a sense, these are treatable in some way. And I'm going to show you some evidence of pretty long run effects, actually, of some treatments on these things, which would suggest that, they are malleable. Okay. I guess I'll also say that, subclinical levels of mental distress are also kind of a thing that matters for people's well-being and are even more common than this, right? So a couple of other facts about this, which is women are about 1.5 to 2 times as likely to show symptoms or report symptoms of depression and anxiety. This seems to be true in kind of, most countries. As I mentioned, the onset of mental ill health often happens in adolescence. So notably for us, also as economists, at a very critical time in terms of human capital accumulation. I think we don't really know enough about how this actually affects human capital. The COVID pandemic worsened mental health for all groups. So that's this kind of shift from the blue to the red, I should say. On the x-axis in this graph is age, and the y-axis is this kind of prevalence separately for females and males. And you see kind of the shift up during the pandemic. And to some extent, this has shifted back down, but we're not totally sure to what extent. There's another striking fact, and this is data from the US, but in, I think, every country that we seem to have decent time series data for, we've seen a really sharp increase in rates of depression and anxiety, self-harm in many cases, suicidal thoughts amongst young people. So this is plotting on the x-axis years, and then each of the different lines is a different different age cohort, or not cohort, different age groups over time. And what you're seeing is from around 2010 onwards, you start to see a very striking pattern of an increase in kind of depression amongst young people. And then this is starting with people who are in 12 to 17, then as they're getting older, you're starting to see with a lag that increase amongst young adults as well. We don't know enough about developing countries in terms of having good time series data, but wherever in the developing world you look at, say, recent cross-sectional data and things, data we've collected in India as well, you see a similar pattern that rates are really high. So for example, we find something like 30% of college students in Chennai seem to have symptoms of at least moderate levels of depression. Colleagues of ours have found, reports of suicidal ideation amongst 10% of college students in Chennai. And, this is not a city we picked particularly because we thought there was something wrong there. Similar data in Colombia that we've seen recently.
Gautam,
yeah.
Just a clarification. I know you thought about this, which is how much of these numbers do we take as improvements in measurement reporting versus reality? And so just so that, is that an issue at all to think about or no?
That's a great question. I should have specified. These data are coming from, or data like these for the UK, for the US, are coming from sort of representative or close to representative population surveys where you're asking people about the symptoms. So it's not that you're asking them, are you depressed or have you been diagnosed with depression? It's trying to do it kind of public health style. We go and ask you about the symptoms. There is still a little bit of this issue of, is it that young people are now more comfortable reporting symptoms of depression? And that's where we end up getting into kind of this fuzzy territory of ultimately it is a subjective condition. It's about how you're feeling. We do see increases in, forget if I have this here. So, we do see increases in things like self-harm. So things like cutting, for example, or, suicide attempts in some cases. So, that feels like a more objective kind of measure. And we see increases in that as well. Yeah.
So the graph is really the cohort effect or
I think it's a cohort effect. I think we can't separate these things totally, but it seems like it's a cohort effect. And as these kids are then getting older, they're carrying that worse mental health with them. Now, as they get even older, maybe something changes.
So this is holding the 18 to 25 cohort constant. So those people who were in those ages in 2009.
So what this particular graph is doing is, sorry, the composition here is changing as you move along. It's sort of always saying, okay, who is 18 to 25 in this year? Who is 18 to 25 in that year?
If there was a scattering effect, then you would observe an uptick in the one of the two.
Exactly. Yeah, I think that's right. Yeah. Okay. So that was from the US. This is from the UK, from the Millennium Cohort Study. And already you guys might be thinking about, is this about social media? And that is really one of the most commonly discussed kind of culprits for why are we seeing this increase amongst young people? And it may well play a role. So what this graph is showing you is how much time do you spend online or screen time separately for girls and boys in the UK. And that's on the x-axis. And on the y-axis is the percent of this population that has self-harmed in the past year. Okay. And you see that it's sort of much higher, like amongst people who are spending a lot of time online, girls who are spending a lot of time online are more likely to be engaging in self-harm. Obviously, this is not causal. There could be a lot of other things going on. Okay. This is from the US now, pointing out that, over time, the share of US teens who rarely meet up with their friends and who also say, it doesn't feel good to be alive, kind of goes up together, and you see sort of this increase quite a lot in the so-called smartphone era. Okay. Now, as economists, of course, we'd say, well, it would be good to have some causal evidence here. And there is a little bit that we've started to accumulate, and I think a lot more needs to be done. Alcott et al. I think the AER have kind of this famous paper, which is taking college students in the US and randomizing, giving them incentives to deactivate their Facebook accounts for maybe just 4 weeks or so, not a very long time. And for them, mental health was not, a key outcome they were focusing on. This was, they were looking at also learning about politics and, just in the context of an election coming up. But they really found that, improvements in things that seem like they're proxies are related to mental health. So subjective well-being improved when you went off Facebook, and the effects did seem to persist for a while after that as well. Okay, you see this substitutability between online activity and offline activity. That is, you spend more time with your friends in person if you're spending less time on Facebook. Okay, there's a paper that's using observational data and a kind of staggered diff and diff approach, Braghieri et al. Also in the AER, looking at when Facebook rolled out across different colleges in the US. So way back when Facebook started, it was restricted to particular colleges, starting at Harvard and then other places. And they went and looked back at some sort of student survey data there and argued that there's evidence that when Facebook shows up, pretty quickly, within a few months, mental health gets worse, particularly amongst students who would be a bit more socially excluded on campus. So one possibility is something like you now start to see all these photographs of all the parties your friends, your classmates are going to that you're not invited to, you're feeling more excluded. I think there's some, this is interesting evidence. I think we could use a lot more along these lines. And surely it's the case that there's a lot of variation in the cross-section still, right? So you kind of have this pattern of social media and smartphones, sort of took off. Mental health got worse, but it's clearly the case that it gets worse for some students, for some young people, and not for others. We'd like to understand where that's coming from. We actually just don't know how much this has been a driver of mental ill health in developing countries, right? So, for example, I actually don't know in rural India, have you seen the same sort of increase in depression, anxiety, suicidal ideation amongst adolescents and young adults that I've seen in sort of cities in India, because in rural India, at least until recently, kids still weren't on social media and weren't on smartphones, but perhaps we would see the same effects there. That would be quite informative, and I don't think we know the answer to that question. Yeah.
Is there similar evidence coming from the medical literature? And if I may ask a question, I've always wanted to ask you and Luca and others, if you submit the same, take the Braghieri and our papers, submit that to a medical journal, what would they like and what would they complain about?
Yeah, so in the, I feel like in the public health and kind of medicine world, right, there's two kinds of evidence. One is really gold standard, gold-plated RCTs with often, I think, with very good control, sometimes almost, I think, too good control, like, the way in development economics, perhaps sometimes we've made early on we're doing experiments where you just couldn't possibly scale this. So, there's that kind of evidence. And then there's all bets are off correlations. Right? So what medicine and public health has not embraced is natural experiments, the way economists have kind of put a lot of effort into, finding applications for diff and diff and regression discontinuity. That's not a big part of the literature there. So in some of the kind of review pieces we've written, we've tried to kind of introduce that and kind of work with people from medicine on that. So I don't think they would, in a way, distinguish the Bragieri et al. Paper from the correlations. To look at correlations of social media use and mental health, I think it's a bit all over the place. And it really depends on what else you're controlling for. Okay, so I should say we don't really understand like through what mechanism social media is harmful for mental health. I mentioned this idea that it might be you feel more, you realize how low you are on the totem pole or something. It could be that it's because you're just spending less time in person with your friends. So earlier this summer, I was doing some, field work in Delhi, and we were doing focus groups with Jishnu Das, with school students, and it was just striking to me how structured, kids' time was, like compared to when I was growing up in India, whatever, 20 years ago, where you'd come home from school and then you'd just be kicked out of the home by your parents, and then you're doing stuff for a number of hours, right? And now I found that kids are getting to see a friend maybe once a week outside of school, if that, right? Because they're just, the day is totally structured and tutoring and this and that. And then they're, watching, they're borrowing their parents' or brother's cell phone to do a bit of, texting or Instagram. So, is it about that? Is it about seeing people in person? I don't think we really know. And what can we do to actually improve people's online experiences and kind of protect their health there? So, and basically, I think for all of this, we know a tiny bit from rich countries, and we know pretty much nothing, I would say, from developing countries. And we just don't know how different that is. Okay, well, what about the relationship between mental health, poverty, economic development, growth? First, it seems like, the contrary to what people thought a few decades ago, when mental health, things like depression, anxiety were described as sort of, diseases of affluence, like you have nothing better to worry about, so you sit around being anxious. That's just not true. So within a given location, within a given context, one tends to find that poorer people have worse mental health. So this is within India, it's not really great. And, it's not the perfect kind of data. I don't have the micro data here, but different kind of income quintiles. In India, we find kind of the prevalence of depression is lower amongst people with higher income. Jishnu Das and co-authors have established that the relationship with consumption is kind of much flatter than the relationship with something like income. Okay, so economists think of consumption as kind of the measure we care about often, and so can't be sure, but one thing that I think this discrepancy suggests that there's some measurement issues and so on, but part of it is that mental health probably responds to shocks, to things like shocks to income. Consumption is something that we kind of smooth much more, right? So that would kind of explain why consumption isn't very as much, and like that relationship is a little bit flatter. But some review papers, which I think in the global mental health literature, they take a very expansive notion of poverty compared to economists, not just focusing on consumption. And they would argue that the poor are about 1.5 to 3 times more likely to experience depression and anxiety compared to the rich. Yeah.
Could it just be that savings reduces anxiety?
Yeah, absolutely. I think kind of, the public health world is not really thinking about consumption smoothing, savings, and, some of these things. So, some evidence we have on, not quite savings, but things like, say, health insurance, improving mental health. So the famous Oregon study by Amy Finkelstein and co-authors, which randomized providing health insurance to people in Oregon, found that mental health improved. And, that didn't seem to be, physical health didn't improve. And we suspect part of that is you're just less worried about being bankrupted by a potential, health shock. Okay, now here's the thing that has made some of my psychiatrist co-authors, nervous, and I think, maybe for good reasons. Even though I showed you within a given location, poor people seem to have worse mental health, I don't think we have any evidence, really good evidence of that holding across countries. So these are data from the Global Burden of Disease study, where different countries, health authorities in countries are supposed to kind of report these health stats. And if you look at these, you would think, if anything, richer countries have higher rates of depression and anxiety. I think we want to take seriously that this may be true, but definitely there's a caveat that exactly how the reporting is happening is differing. It's very difficult to get to the bottom of. For me, I couldn't quite figure it out. These are, in principle, a lot of these are supposed to be from population studies, which would not be confounded by just differences in diagnosis rates. But my sense is there's some mix of different countries report in different ways. And so part of this just might be in which countries you diagnose more depression and anxiety. Yeah.
You also looked at inequality or change.
People have looked at this stuff, and, inequality seems to higher inequality seems to be correlated with worse mental health. It's kind of hard, just really, as economists, we might kind of have a very clear conception of what we're holding constant and what we're changing. And I think we just don't know that well. You might think that, so as I said, relative poverty may really be a thing that matters. But, I suspect things like economic growth really matter. If there's widening inequality, but everyone's feeling like things are really getting a lot better, that might be quite different than, the pie is really fixed and inequality is widening. Okay. So I guess all I'm saying is that unlike something like physical health, where you always, you basically always find that like richer countries, people have better physical health, we should at least be a little nervous about whether that's the case for mental health. Okay, I don't want to overstate beyond that. Okay, I mentioned that one reason economists should attend to mental health is that economic policies seem to affect mental health. So what are some examples of that? This unreadable thing on the left is from a paper we have in Science. Oh dear, that didn't compile. It's Ridley et al. 2020. This is a paper co-authored by 3 economists and a psychiatrist. And one of the things we do is like a little meta-analysis of different kinds of anti-poverty interventions in developing countries and what effects they have on some of these survey measures of depression. Okay, so these are cash transfers. And then in some cases, they are kind of these, things like the ultra-poor graduation program or other similar anti-poverty programs that do cash or asset transfers and also other stuff. And these are all from RCTs. So, countries, reported include, let's say, Mali, Ecuador, Zambia, Nicaragua, South Africa, Malawi, Liberia, Kenya, Uganda. So, quite a lot of places. I guess mostly in Sub-Saharan Africa, some in Latin America. And what you find on average is, multifaceted anti-poverty programs on average are kind of improving mental health by 0.14 standard deviations, cash transfers by 0.07. If you do a per dollar comparison, the cash transfers are just much cheaper than the multifaceted ones. So if all you cared about was mental health, in a cost effectiveness way, the cash transfers seem to do quite well. And there's kind of similar, frankly, better and more thorough meta-analyses that have recently been done with similar findings. Okay. Just an older paper doing like a diff and diff type thing, looking at a cash transfer program in Indonesia that rolled out and found that this seems to reduce suicide rates, particularly in districts that were hit by droughts, right? So when districts are hit by droughts, suicide rates go up. But if there's this government cash transfer program going on, that reduces the kind of effect of droughts and sort of therefore reduces suicides. This is a really interesting recent work, Hassam et al. Paper in the AER, which studies Rohingya refugees in Bangladesh and does this really thoughtful experiment where some of them are offered jobs. Some of them are instead just given unconditional cash, the same amount that they would earn from the jobs. and a control group gets neither. And what they find is these measures of mental health, psychosocial well-being, depression scale, stress, your sense of kind of, your sociability, locus of control, all of these things improves when you get the actual work, where you feel like you're going out there, doing something useful, maybe also interacting with people and so on. But you don't get the same effect in this context just by giving people cash. So it's suggesting that employment has some benefits for your mental health beyond just kind of the income effect. And I think these authors have sort of replicated and built on this result for some newer work that they're doing. Okay. There's also a really nice literature on early life conditions, which can have long-lasting effects on mental health, right? We know that things like, say, shocks, when you're in utero, have long-run effects on human capital accumulation and so on and so forth. Turns out they also affect mental health. So Person et al. Paper showing this is sort of, in a way, this is not quite an economic shock. This is the death of a mother's relative, which is sort of an instrument they use for exposure to stress, before you're born, when you're in utero, seems to affect, seems to cause depression later in life. But also economic shocks. Achadvaryu and co-authors show that a decrease in crop prices in Ghana, at the time of birth, predicts more anxiety and depression later in life. So we might really think that programs that provide financial support for households with pregnant women or young children might have long-run health benefits. Okay. So that was saying, well, we can use some economic policies to improve mental health, or at least the benefits of some economic policies might be even more than we thought once we are accounting for these mental health, subjective well-being benefits. But what about actually directly trying to tackle depression and anxiety the way psychiatrists would? I'm going to say just a little bit about pharmacological treatment. I actually think there should be much more research by economists on pharmaceutical treatments for depression, whom they work for, how long they help, what the economic consequences are. There's a little bit of work, but I think, nowhere near enough. So antidepressants, you guys may have heard of or use things like SSRIs or SNRIs, are effective in, reducing symptoms of depression and even causing kind of remission for maybe up to 60% of patients. And so in a way, from an economic perspective, a lot of these things are also now generic drugs. So, they're kind of pretty cheap per pill produced. So you might think that just getting these out there, gosh, that's relatively cheap to do. But they are dangerous in some ways. They, ideally you want them to be delivered under careful supervision from a psychiatrist, and you really need to kind of check in and see how they're working, because it's very common to require to try different drugs until you find something that works for you, and to vary the dosage, right? There's side effects, and some of the side effects can be very serious, including increased suicidal ideation when you first get onto a particular antidepressant. If you come off them very suddenly, that can have severe side effects. So, these have to be done carefully. We don't really understand at all kind of the biological mechanism for why these things work. We don't understand which ones work for which people. So it is kind of a difficult thing to get onto. And, almost always there are side effects, and some of those can be quite serious. Angelucci and Bennett have a paper in Bangalore, now forthcoming in the AER, where they cross-randomized referral for pharmacological treatment and livelihood assistance for depressed adults in India. And they found that the combination of the two had longer lasting effects on mental health. I think one challenge with this paper is it's a little hard to know what actually did people get the drugs. You can't quite tell from the paper how many people actually got the drugs, kept using them and so on and so forth. But I think it's a really important first step. There's a very nice paper by Biasi et al., which looks at when lithium was introduced as a treatment for bipolar disorder, which is a kind of more serious kind of mental health condition, and showing how in Denmark, you can see in the amazing Danish data when someone gets a diagnosis of bipolar disorder, and you can see that before that, their labor market earnings and stuff are going down as the condition starts to manifest, and then just keeps getting worse after the diagnosis. But then when lithium arrives, you can see sort of it gets less worse after the diagnosis. It's still kind of going down, but much less so. So clearly pharmacological treatments are important. Not many people are actually receiving them. I'll say a bit more about that. But equally, and this is the thing I've kind of worked on more, and I'm fascinated by both intellectually as a behavioral economist, but also just from the kind of policy relevance of the thing. Psychotherapy is highly effective for treating things like depression and anxiety. It's often as effective as medication, at least for, I think for, say, for example, a severe case of depression, you're typically going to need a combination of pharmacological treatment and therapy. But for moderate and mild cases of depression, which are, which are of course very common, psychotherapy seems to be just as effective as medication without some of those same side effects, right? These kind of physical side effects. And it might have longer lasting effects. So for pharmacological treatment, you often just need to stay on them forever or for a very long time, whereas a short course of therapy, we now start to have some evidence can actually have mental health benefits for a long time. Cognitive behavioral therapy is a thing that you may have heard of and some of you may have kind of experienced. This is something that has a very large evidence base. The idea is there's two parts to CBT. There's the cognitive part, which is trying to kind of teach you about patterns of thoughts that you're kind of engaging in, which may be unhelpful, maybe unrealistic, and just pointing them out to you, helping you identify them and then change them, okay? But the other part of it, which frankly may be doing a lot of the heavy lifting and some trials suggest is just as good as the whole CBT, is the behavioral part of it. So for something like depression, this means, a classic thing that happens in depression is withdrawal from the world, withdrawal from the kinds of activities that you usually engage in that give you pleasure, that give you joy. You don't feel like getting out of bed. And just getting you to re-engage in those activities and teaching you the relationship between the activities and the mood that they engender seems to actually be quite effective in treating depression. So these are the kind of the two broad parts of CBT. And there's really a huge evidence base of effectiveness. And this CBT approach has been used for many things. There's CBT for anxiety, CBT for insomnia. I'm kind of here mostly referring to the CBT for depression. Okay. So these treatments exist, and I'm telling you that they're effective. So great, what's the problem? Well, the problem is that, frankly, this is a conservative estimate. At least 85% of people with depression receive no treatment at all in a place like India. In sub-Saharan Africa, I think that number is even higher. Okay. And in fact, even in rich countries, about half of people with mental health issues don't seek or perhaps don't receive mental health care. So these treatments exist that, at least in the clinical trials in the published literature, seem very effective. Why are people not getting them?
Question here. So what do we know about if people are at all aware that they do have mental health disorder?
Yeah, it's a great question, right? So you can ask people the symptoms and they may say, yeah, I had trouble sleeping. Yeah, I don't have any pleasure from anything. But so in that sense, but then you say, are you depressed? He might say, no, what's that? Or so I think those things are changing a lot also. So for example, say with college students in India now, everyone's heard the word depression. It may be used in a much more casual sense, the way we often do just in the English language, say, oh, it's so depressing. But you don't actually mean clinical depression, you just mean something that bums you out. So I don't totally know the answer to your question. And I think certainly as mental health literacy increases, the answer to that will change. So do people identify as needing some help, for example? I think often not. So my casual experience, or not casual, like trying to do RCT experience, but not published and so on RCTs, is that people think that things like going to a psychiatrist, getting therapy is for someone with much more serious condition than them. Mm-hmm. So in a place like India, for example, right now, something like schizophrenia, paranoia, like you say, yes, okay, this person has to go to a mental health professional. And if you ask people, should people go to a counselor if they're depressed? Absolutely. Do you need to go? Even though we've screened you and found these symptoms of depression are pretty high. No, I just need to talk to my friends and I'll talk to my mom and I just need to talk to my friends. I need to work harder, it'll be fine. So, but people say other people need to go, but themselves, they kind of, I think part of it is you feel like you only need help if it's very, very serious and your condition is not so serious. And frankly, I have to say, personally, I felt this myself, like even in the US, feeling like, oh, I'm not, I shouldn't take someone else's space and, other people need it more. So I think that is probably kind of an issue that's pretty common. But I think the first order issue is just that there's enormous supply side barriers. So this is also in the US, if you want to go find a therapist, it can be really hard. Finding a good therapist, even harder. I know some very good therapists in the Cambridge area. Many of my friends have benefited. Okay. There's also, some evidence, and these are things we are working on, and these demand side barriers, which I think are really interesting. But just to give you a sense of the supply side issues, what this graph is showing is in low, middle, upper middle, and high income countries, per 100,000 people, how many, say, psychiatrists do you have? Right? Yes.
Do you know if there's any intersection between the demand and supply side problem where you try it out and then the next appointment is 3 months later because our therapist is so oversubscribed, they never want to try again, or maybe you never get an appointment in the first place?
Yeah.
Like, how does that?
I'll show you if we have some work. I think I won't get to it, but in India, which shows that sort of the reverse, which is if we get you to try therapy, you end up becoming much more positive about it. So there's some positive updating in like Goa and India from trying therapy, and you actually end up with pretty accurate perceptions of its efficacy, whereas the control group who doesn't get to try it underestimates it. But you could certainly also have the reverse, that I start off being optimistic, I don't get to try it, and I just kind of sour on it. I don't know about that.
Or even if I think it's useful, if the next appointment I get is like 5 months later,
but then it's not useful in some sense, especially with something like depression, which is episodic.
And we know that the first few sessions are the hardest.
Absolutely. So I think that's like a real issue. So by the way, I'll just forget my slides, but I think there's this real interesting issue in a lot of the existing clinical trials on things like therapy. They are understandably these really, done with great fidelity, providing great therapy, I think probably with a lot of selection of participants into the trial in a way that's not fully appreciated, right? So I remember seeing at the economics department at Harvard on the board there, like a notice saying, hey, have you been feeling depressed? Would you like to be part of a clinical trial in MGH? Like that's some serious selection into the trial, right? Whereas in contrast, when we've tried to look at, we've looked at some admin data from a large online psychotherapy platform in the US, right? In those things, or if you just talk to them, you just find massive attrition from therapy, actually. A lot of people who'll make an account for online therapy will never show up for their first session, or they'll show up for one session and never show up again. It may be that and we know for something like, say, therapy for depression, you typically need about 4 weeks for 3-4 sessions before you start to see some benefits, right? Yeah.
No, usually we understand, I don't know other, but in India, that this is an urban-centric problem. That rural people, they may not come up with this problem because they are living happily to some extent, talking to many people, but in urban like cities, they are excluded and they don't have connections. So that made them more. So do we find that this is the case, or is it like in rural area also we face this?
Yeah, that doesn't seem to be the case, actually, and this is partly maybe income differences and so on. Actually, I think, rates are just as high, in some cases higher. So if you look at the US as well, for example, rates of depression are, I think just as high or even higher in rural areas. We don't have as good data often in places like India, but for example, if you look at one proxy, which is say suicide rates, we actually have higher suicide rates in rural India than urban India, right? So, now suicide is not just the same as depression, but it's something that often goes with it. So, I think we need to understand better these differences, but I don't think it seems to be the case that it's just an urban problem. If any, there's some evidence that it's worse in rural settings.
Thank you.
Yeah. Okay, so developing countries have really not invested in kind of mental health services. And in fact, this is also true relative to physical health services. If I were to instead plot kind of, this gap between this slope between developing and rich countries is steeper for mental health care than for physical healthcare investments, right? Okay. So what are some potential solutions? And then I should stop.
Can I ask you something about the supply side?
Yeah.
So I think that in both low and high-income countries, you have substitute to psychiatrists. You know, like some people will see like a life coach or something a bit more informal. So do we have any numbers on this? Like that's sort of.
Yeah, I mean, so here we do include things like, social workers and so on. My sense is what happens a lot in developing countries, and I don't know here about the differences, the usual approach to dealing with these things. Sometimes it could be like a religious faith healer or something like this, but most often, and this may be appropriate as well, it's mostly social support. You want your family, like the first instinct is friends and family. Every young person I would talk to, I say, what would you do with this? I talk to my friends, I talk to my family. So there's a lot of that, and I don't know how different that might be across rich and poor countries. Okay, I'm almost out of time, so let me just mention two things. First, that there's this remarkable and growing body of evidence that in low resource settings, you can deliver very effective forms of therapy for treating things like depression and anxiety, not using psychiatrists, not using psychologists with bachelor's or master's degrees, but literally hiring someone who's kind of pro-social and has good human interaction skills and giving them a few weeks of training, okay? And the advantage of some psychotherapies like CBT is that they're what is called highly manualized. So you just have like session 1, do these things, session 2, do these things, and you can train people to do that. You need to kind of keep giving them some mentoring and support and supervision over time, but you can deliver pretty effective forms of therapy. There's another thing which is now kind of the Wild West out here in rich countries is we don't really know, not as much action yet in developing countries on using things like AI chatbots, apps, etc., to kind of use technology to deliver these things. I think this is also potentially exciting, but the existing evidence suggests that it's just really hard to get people to actually use these things. You might download it, never open it, use it for 5 minutes, then never stick with it. Whereas if we can give human and kind of sort of complementarity to kind of support you sticking with it, this might be quite efficacious. I'll leave you with one last thing, which is, a 5-year follow-up study we did. So there was some psychiatrists had done a study of what's called the Healthy Activity Program, a treatment that cost all included, including training the therapist, transport costs, all these things, $66 per person to deliver. And they had shown that for 3 and then 12 months, this had reduced depression in a general sample of adults in Goa and India. We went back 5 years later and basically found that the effects still persisted. Okay, so what this thing was doing is averting about 9 months of depression over 5 years, so about like $7 per month of depression averted. Okay, so these things exist. We still need to figure out kind of how to, open questions? No? Okay. My open questions are going to be kept highly secret. We still need to figure out how to really scale these things up from, trials of 1,000 people to can we do this across the whole state and so on. And there's some amazing people like, Vikram Patel at Harvard Medical School who are working on this. My sense is a lot of these folks in global mental health, we have a lot to learn from them in terms of implementation science and doing things. But they're also eager and open to collaborate. So I would be really thrilled if, some of you were to, start doing that kind of work, working with psychiatrists. I think these are some of the most important, problems we're facing. And I think there's a lot of both intellectually interesting, but also important for welfare work to be done. So thanks so much.